Hello, everyone. Welcome to the Road to Recovery podcast. This podcast is a platform for education, discussion, and conversations on mental health. I'm your host, Amira Shah, and in this podcast, you'll get to know more about the therapeutic process, insight into life from the perspective of the psyche, and also join me in exploring current issues with other practitioners. I specialize in grief, but I'm always interested in learning about the human experience of the mind, heart, and spirit. So join me on this journey of in-depth learning about ourselves and the world we live in. Hi, thank you for joining us today, Mary Weru. Today I'm with Mary. She is a social worker working as a senior case manager in sexual health and blood-borne virus in the Northern Territory. Hi, Mary. Thank you for joining us.
Hi, Amira. Thank you for having me.
Mary, we used to work together some years ago in Darwin, and I just want to say it's really, really nice to reconnect with you after all these years.
Yeah, it's really good to be in touch with you, Amira. I've always enjoyed anytime we get to spend together. It's insightful and it's fun and it's full of smiles. So
for our listeners, Mary and I, we shared an office for a period of time, and I truly believe that the both of us had the biggest smiles. We were always grinning. I don't even know why.
I can confirm that.
and you were sitting in front of me, kind of, and it's almost like we just kept beaming off each other in terms of like teeth.
Exactly.
You know, I think if we were around baboons, we might have been attacked. Because they feel so threatened because all they'll see are like our teeth flashing. You'll probably start baring your teeth and clawing at us.
Yeah, it's like that sometimes. You know, someone will say, "Oh, why are you smiling?" And it's like, oh, kind of the default.
I'm not complaining. I enjoy laughing. I enjoy smiling, and you are.
Yeah.
With your presence, it's quite contagious. So I think we just amplify. We just amplify it.
Yeah. Yes.
Anywho,
that's good.
Yeah. So you're still in the NT, and
I'm still here. Never left.
How long have you been there now?
NT. It's going to 10 years now.
Wow. Where were you before?
I'm becoming a long term. I was in Adelaide, so South Australia before then for about 10 years as well.
Can you tell us a little bit about yourself?
I initially started off my career in business. Well, I came to Australia as an international student, studied a Bachelor of Commerce, and so I thought my work life would go into business. But while I was studying, I worked with people, so I got into human services when I was a student. But I thought that when I graduated, I would go into commerce and business. But it didn't work out that way. I think the human services and the people professions fit me, my personality and my existence a whole lot more. It makes sense. So I've since then worked in human services or community services until when I came into NT and I was working in public relations. And I happened to go into Indigenous health. So I was working for a community-controlled Aboriginal corporation in health. And I just found so many concepts that I was excited about, but I didn't have the language to explain. And I think in a way that sparked an interest in social sciences, like formalizing because I could see what I wanted to say, but I didn't have that social sciences kind of a backing. So I went back to uni and did some study in social work. So I did a master's in social work. And so I've been working as a social worker since then.
Wow, that's quite a
Yeah.
journey. And you started off in a really different place to where you are now.
Yeah, definitely. Definitely. So I had no idea things like social work existed at all. I didn't know that.
Really?
Until I found myself in it. And then I thought, why didn't I know about this earlier? I'm so happy that social work exists. I like it. I enjoy the knowledge in it. I enjoy the concepts. I enjoy the because it's about people. It's so human. It's really all about people, and people are my thing.
Mm. That's why you're always
Yeah,
smiling, because you're always working.
I think so. Even without thinking, if my eyes meet another person's eye,
Mm.
even without thinking, my face just goes into a big smile without me thinking. And so usually what I notice is the other person smiling back at me.
Mm.
And what I normally don't always think is that I started it.
Mm.
I was smiling back at you anyway. So good. It's good fun. It's good to smile.
That's interesting. Okay, cool. Thanks for
Yeah.
sharing that. Now, can you tell us a little bit about what you do now? Because when I met you, when we were working together, I mean, correct me if I'm wrong, you were a case manager.
Yeah.
Yeah.
So when we were working together, yes, I was case and services coordinator or something like that.
Mm.
In what were we working in? Yeah.
Refugee?
So yes, refugee. We were receiving people from refugee backgrounds and supporting their settlement. So after that, I went often to have a baby and maternity leave. And then, so when I was thinking of coming back into work, I saw this really simple job that I thought it's a really simple job. I just need a few hours to get back into the work environment. So it was an intake officer role. It was a part-time role. When I went and interviewed for it, I had a mind blank, I had not worked or interviewed for about over a year, or so I felt I was really less than average. But they said they wanted to see me again, and I thought, oh no, why would they want to interview me again? Was I not embarrassing enough? Because halfway through the interview, they'd asked me a question and I just went blank, and I had within me, I just gave up on it. I thought, oh, maybe it's just not time for me. So I just said, actually, I really don't know. That was my answer to this question of,
Mm.
I think it was something like something about systems theory, and I said, I have no idea. Anyway, they called me and asked me, would I consider being a counselor? And I said, well, I'm not sure that I'd make a good counselor because I haven't really, other than the incidental, I'm on the way to working on other things, and I find myself, having discussions and exploring concepts with people. I haven't really had the title counselor. And they said, we'll support you and we'll see how you go. And if it's not really your thing, then we'll support you in every way. And if you want to move into a different role, we can do that. So I went in and I had zero confidence, and I thought this is the worst idea. But once I got in there, I actually really enjoyed counseling, and I was surprised to see I was already doing a lot of counseling in my roles. It was just not my main focus. So I had worked in housing and with youth, and the whole time you're supporting a person in housing, you're actually doing a lot of counseling as well, because you're reframing concepts, you're using all those skills, the listening, the finding out what's going on there, and what can we do, so I found it interesting now, everything else being removed, and you're in this room with a person for like an hour. And that was I felt like that was going to be my worst nightmare. Like, how do you put me in a room with another person for a whole hour? What will we talk about? And then once I was actually in that room, I found, first of all, the hour goes so quick that half the time you're thinking, I need more time, or we need more time.
So true.
So my biggest fear was this whole hour, because in my mind I thought I'm going to be sitting with this person in this room with a door locked, and we'll have nothing to say to each other. But it's not like that at all. And I found it really engaging and challenging in that I had to go and find so much more information. I had to go out, like a person will bring their situation to me, and we are both sitting there. They're guiding me and taking me through their life, what's happening for them. And then I have to find a way to sit with this while holding that space. And yeah, I found myself having to look for so much more knowledge, so many more, skills, and just to work in this thing. And I really enjoyed. So that kind of was my start journey into coming into my current job, because it needed counseling skills. So my current job is a case manager, a senior case manager, but it needs counseling. So sometimes people in my work have received a diagnosis, they are not too sure what to do with it, and they're in shock, or not knowing, is this the end of my life? And just sitting there. Or sometimes people have experienced, loss, and so they're grieving. Sometimes we have people who have had a mental health diagnosis, and they're trying to navigate through services, and what do they do? And sometimes people are facing stigmas because of a condition they have, or all sorts of interesting things.
Well, thank you
Did
for
I
sharing
answer your
all
question?
that. Sorry?
Did I answer your question?
Yeah, I was really roped in there because when we reconnected about a month or so ago, and you told me what you were doing, it really piqued my interest, and I was really surprised that I didn't know that there was such work going on. But I remember you did mention as well that it's a new role.
Mm.
So,
So,
mm,
yeah. So, yes, the role sits in the public health unit. So, but they haven't had a social worker here. So it's mainly doctors and public health nurses. It's always been like that. But then, because sometimes we work with people who are under the order of the chief health minister, the CHO. So they want to have that social work perspective. So it's a new role, but to me, I feel like it's so necessary. It's so necessary
mm,
because of the advocacy and of the whole story. I feel that social work has that focus on the whole person, not just the medical bit. And that story influences a person's behavior. It influences their mental space, or where they're at. It influences. Um, they don't just wake up and make decisions based on a medical thing. It's
mm.
everything else that's driving them, and having, um, yeah. So it's a new role. I also didn't know about it, but it's been interesting because I'm not particularly an expert in sexual health or blood-borne virus, but I know about social work. I know about advocacy. I know about the things I can do are what I contribute to the role. Yeah.
So you're the bridge between the medical team and the clients, and you not only absorb the medical information and treatment and interventions, but you also um, deliver this information in a holistic, humanistic way to the clients so that their psyche or their psychology and their behaviors can um, be tailored towards a better well-being because they would understand and receive and reciprocate accordingly.
Yeah, it's like a bridge or an interpreter of the health people want this person not to put other people at risk.
Mm.
And this person is just living their life. They're not waking up saying, today I wake up and what I'm gonna do is put other people at risk just to piss off the health department. They're just living their life. Um, and so my role is to kind of understand the outcomes that the health department is looking for in this person's life and find ways, how do I support this person to do all these things without restricting their lives, without punishing this person for who they are, without how do you interpret each other's worlds and meet each other's expectations and goals without because I find that when organization and individual clash, usually it's the organization that will win. So it's mainly being a buffer for the individual and making sure that their voice or their story is heard and that their story informs I don't know, something
So
something like
that's
that.
the advocacy bit again. So um, the the reason why I keep hearing a lot of advocacy in your work as well is probably because I've been teaching recently, and a lot of the
Mm,
content that I'm covering when it's counseling populations from diverse backgrounds or fringe
excellent, yeah,
populations, a lot of advocacy
yeah.
work needs to be ingrained along with the counseling work because
Mm,
there's a lack of awareness or understanding by the general population, the mainstream population, and systems about certain
mm,
groups. It's just a
yeah.
lack of awareness or some form of historical marginalization that is on the mend now, but it's, still got to
Mm,
go. And while you're in the counseling room doing counseling, you also have it's like you have three CPUs or four CPUs running at the same time. You've got the
mm,
emotional
yeah,
CPU, you've got the cognitive
absolutely.
CPU, you've got the sensory
Mm,
CPU, and then you have working memory that has to tie
yeah,
everything
yeah.
together. And they're all working in
Mm,
tandem. And then you also have to come up with a way to make sure their voices are heard and to make sure that there's some
absolutely.
things in place for some
Mm,
long lasting or solid change, systemic change that can help them get the support that they need.
mm, absolutely. And the impact of if that support isn't there. So, for instance, if I'm working with someone and their situation is there are things impacting them, for example, AOD use or homelessness or something, and say the health team is trying to deliver medicine to someone and they said they'd be there at 10:30, so the health team goes there, they're there at 10:30,
Mm.
and this person is not there, and it's and it's frustrating because you've organized your day and you want to deliver this. It's important that this person has this medicine because that's how we'll manage, say, the viral load in someone's bloodstream. So if they don't take this medicine, the viral load will go up, and that means they can infect other people. So it's important that this person has this medicine. They said they'd be there at 10:30. They're not there. Now, this maybe from a worker perspective is like, you don't take this very seriously. But then from the individual's perspective could be, well, it started raining and I'm homeless, so I live at the beach. It started raining, so I had to go and find somewhere undercover to be, and I haven't found a way back yet to where we agreed, or I need to follow around my family group or the people that I hang around at the beach with, and that's a real survival thing for that person, because if they don't go along with those people, then how are they going to survive on their own out there? And it's rough sometimes. So they couldn't, the choices they had and the reality of the life they're living, me as a worker delivering that tablet is not the main thing. That's their problem. It's my priority for as a worker, but in the context of that person's life, that's not the priority, because the priority is their survival. And that means following around that family group if they say we need to go because this is how we'll get enough shopping for this week, or this is how we'll, whatever it is, just having supports that respond to the people, to the person's circumstances. And I don't know, it's something like that.
And how do you, I guess, communicate this perspective to the medical team that you work with?
So through reports and feedback, so and through storytelling. So instead of something like saying, he or she said they'll be there at 10:30, I went there at 10:30, they weren't there. It's the storytelling, it's the capturing the whole situation. On Monday we had agreed to meet here. When I went there, that person was not there. So it's still the truth, but it also captures the circumstances. However, it was quite rainy, and there's no shelter at the place where this person usually stays. So it captures the whole situation so that it's not just a story that says did not attend, did not show up. It's more of a story. This is what was happening at that time. And so that over time, it's not just a question of ticks and crosses. It's more of, this is this person's reality. This is that person's viewpoint. And it's through those, through those opportunities, whether it's in the team meetings when we're having briefs and catch-ups, just bringing in a social work perspective, and just saying maybe the homelessness faced by this person is the biggest barrier to us delivering the service. Maybe it's not this person, or it's not that they have a funny attitude or they are lacking in understanding. It's that if we support and address the barriers, then this person in themselves is not the problem. The barriers are the issues. It's not the person. The person is not doing this on purpose, or it's the circumstances they're living in, the impact of that.
Yeah, so
That kind of thing.
it highlights, well, it shifts that notion that this person is non-compliant or irresponsible, and and as a result, maybe with such reporting measures or methods, there's less punitive, I guess, outcomes from the medical teams or the authorities. And then there's also a deeper understanding. You're able, people are able to develop empathy and compassion, and have a real understanding of what these guys are going through, rather than to get frustrated and annoyed and feel as though they've been personally attacked because this person has wasted their time and all their efforts in trying to help them.
Or like it's a waste of resources, you know?
Oh, thank you.
Yeah, absolutely.
Thank you. That's really enlightening. I really didn't know that there was such wonderful work happening where you are right now. I'm happy to hear that. Hey guys, thank you so much for tuning in to Science of the Soul. This is a short interruption to let you know that if you or someone you know are in need of more support, you can find me at Road to Recovery on my Facebook page, my Instagram, or my website at aroadtorecovery.org. I hope you've enjoyed listening so far, and now let's get back to the podcast. Earlier just now, before we started recording, we had a massive giggle. Now, our tone has gone very serious, but we had a massive laugh, and we were talking about something I didn't know about because you introduced the concept to me, and it was completely new to me. You told me about a group of people in the NT called Sister Girls. And I mistook that for sister wives. And now I know very different things.
Very different things, Amira.
So can you tell us a little bit about your work with Sister Girls? Because I know that it is a small population, a minority in the NT and maybe in other areas of Australia, but you've had some contact, you've had some work with them. Can you tell us a little bit more?
So I do have to start by saying I am not by any means an expert on this, my information about it. It's limited on it's based on the limited interactions and experience I've had. But Sister Girls are mainly transgender people from Tiwi Islands, and they're men who have been born as men but identify as women, and usually they are quite a fun group of people, so very outgoing, very fun, and just full of bubbliness. Well, that is typically, but still people with who face challenges of any marginalized population. And so the story we were sharing is we went to see this Sister Girl, and I was with a colleague, and we went. She was staying. The Sister Girl was staying in a place where you go through reception, and we went and did our work. And on the way back, we were having conversation. Well, my colleague was having a conversation at the reception, and so we were laughing about how that conversation was going, because it was like an unspoken war where my colleague would say, so she has moved to this new room and she would like her things delivered, and she would also like, and the reception would say, well, he will get his things delivered to his room. And then my colleague would reply, that's great, because she expressed that she would like. And then the receptionist would go back and reply, thank you for letting us know. He will be supported to receive his. And it was we laugh about it, but it was funny. It was funny to observe. But it's the real thing of that conversation of transgender health and the identity of the gender identity. I mean, if this person prefers to to identify as a woman and use the she pronouns. It's interesting because what factors are affecting us or them, and does that impact on their mental health, or um, does it, because this person, the official name is a male name, and judging by just the physical factors, he's just this tall, handsome dude with broad shoulders and beautiful hair in a ponytail. So judging by just the physical factors, you don't go, oh, you're a sister girl, unless, of course, you run into her in social circles and she's got all her bright lipstick on and she's just got her high heels on, and then you're like, hello there, what's this? But just in a normal day, when you run into this person, in a normal day, they are wearing just a normal t-shirt like a guy would wear and normal shorts. You're not thinking, oh, hello, you're a sister girl. You just think it's another guy. And so it's quite interesting, because especially if you have a guy's name as well, organizations are going by that. And so, like, I've also other times called one of the people I work with, for some reason, was picked up on the streets by police, and so they were in the watch house, and I'm carrying on going, so I've got one of my clients, she's there and she's got, and I need to deliver her medicines, and the person on the other line goes, first of all, the person you're talking about is a man. And then I have to take a deep breath, in all my super woke fighting for his rights or her rights, I have to take a deep breath and go like, yeah, okay, that's what you have on your records. That's great. And or sometimes I'll try to be like, okay, yes, I'm aware, but they identify as a woman. And the other person on the line will be so unimpressed. Listen, the person I have here under that name is a male.
Wow. Okay. So authorities and governing organizations, maybe I'm guessing hospitals and hotels and such, they, like, from my understanding where you are, they're not always very accommodating to the individual's preferred gender identity or reference. Is that what you've been experiencing?
I think it's just the thing of we don't really think about, we don't tend to think about it, when I think it's a normal person process, that it's not something that's in our face, so when you run into a person, you don't think to ask, hi, do you identify as a man or a woman? You just, it's like such a it's not something you think about, And so if I give you a person's name and they're recorded as a male, you're not going to say, it's confusing if someone calls and start referring to this person as a woman. You'll be like, first of all, you have the wrong person. And so I think it's how it's all set up. So there's it's just an interesting observation of, I didn't know before I started working here. And even I find myself sometimes going, depending on who I'm talking to or where I'm at. So if I'm talking to an organization which is like, well, he is here with us and we have him, and then I have to think, okay, so yeah, I don't know.
In some situations, you have to kind of evaluate the outcomes that are more important, and therefore you kind of assess whether or not it is worth going through that she battle if you just need to get something to somebody. Is that something for your mind, or do you persist?
So I think if I'm working with someone who say identifies as a she, then I refer to them as the she. and in my conversations with another person, I'll just refer to them how they've informed me they want to be referred to,
Mm-hmm.
and I just, so I'll keep referring with them, and if the other person asks me why this is what we have, then that brings in a chance to have that conversation.
Okay.
So when that conversation comes up, and then I'll explain. And there are a lot of people out there who are quite flexible about it, or who say, "Oh, is that what it is?" You know,
Right.
it's just that as a first off, it doesn't always come up, or
Right. Okay.
yeah,
People
yeah,
are
yeah.
accepting. They're
But
just confused initially.
exactly,
Okay. Well, thanks for that. And, I was in Darwin for a while, and I've never crossed I've never crossed paths with sister girls or known anything about them. So thank you for sharing that with us.
yeah. There's a whole population out there, and it's interesting. It's interesting.
Yeah, I bet. And what do you think are
Yeah.
some of the stigmas client that your clients have, including some of the sister girls that you work with?
Mm, I think the stigmas in sexual health or with blood-borne virus is the stigmas are around. You think there's only a certain person who can have a blood-borne virus, or you think, oh, maybe they're sexually loose, or maybe there's something they did so they deserved to get it, or there's something like that, or don't relate with them because you catch it too, or something of the sort, you know. So which results in isolation and marginalization, or um, maybe people not wanting to offer services to such populations. But all of it is just lack of knowledge, really, because any person, including your neighbor, your doctor, your teacher, your anyone, could be having a blood-borne virus, and anybody can catch it, and most of them are treatable. You know, so you can't just catch it off someone just by sharing a house with them, or sharing a workplace with a person. In fact, most likely we all are probably sharing workplaces with people who have a blood-borne virus or something. So, and they're professionals, they're in all walks of life, in every walk of life. So it's the stigma sometimes is even internalized. So I can think, oh, because I have a certain condition, if people find out, they will not um, treat me the same way or view me the same way. And sometimes that's true. When people have found out someone is positive for a certain condition, sometimes the experience is that people have treated them differently, and sometimes that's just lack of information and fear, and yeah, yeah.
Can you give me an example of, or a few examples of blood-borne viruses, I guess, stigmatized society?
Well, yeah, mainly HIV, I think, is the most stigmatized,
Mm-hmm.
and hepatitis. So most people, when who hear someone has HIV, they just think, oh, you must have been reckless, or you must have been, those kind of thoughts or stigmas. Or if you have hepatitis, or you must have been using drugs and you were sharing needles, or there's something filthy and dirty about you. But actually, that's not really the case at all. It's clean people. It's clean people who are doing well. It's people from all walks of life. It's professionals, and some people are born with it. Sometimes some people have acquired it in the course of their work, say through needle injuries. Some people have caught it through, um, yeah. So it's the stigmas most of the time are just lack of information, but they have a real impact on the people who are stigmatized. and of course the lack of knowledge where people think, oh, if you relate with someone who is HIV positive, you're going to catch it. But in real sense, people, you can have a partner who is HIV positive and have a full relationship and not catch it because it's managed. It's fully managed with medication. So the viral load in the bloodstream is actually undetectable. So even if you have, exposure with, if someone is exposed to your blood, they actually will not catch it because the virus is not even detectable. You can have it and have children who are not positive. You can have it and still have your full life. It's just that little added burden of you have to be taking medications, and you have to be, because it's a reportable condition. It means every so long you have to take blood tests just to show that the viral load is still undetectable. Things like that.
Oh, thank you for that information. I remember working with some clients, a couple of clients who were HIV positive, and I wouldn't have known, I wouldn't have guessed, and none of the family members or kids or even the partners had it as well. So I was actually quite confused because I knew that I didn't have enough information or knowledge around it, and I guess I didn't have the opportunity, nor did I continue to search for it. I just knew that the medication was at a level where it's manageable and you don't spread it anymore, and it's just like any other virus that lives in your
Yeah.
CNS, pretty much like
Yeah.
herpes or something like that. You just need to manage it.
Mm.
So I just imagined it might be something like that. And I was really, really glad to hear that, modern science, medical science and technology has really brought us to a point where you don't die from HIV anymore. It's not a death sentence.
Mm.
But to learn so much more from you, like the nuances, the details,
Yeah.
yeah, it's really informative. Thank you. Is there anything else you want to share with us with regards to sexual health and blood-borne virus that you think we can all benefit from knowing?
I think educating ourselves so that we are not stuck in old thinking patterns, whether, like, sometimes if I say to people, oh, I work in sexual health and blood-borne virus, and it's like, oh no, poor you, you're working with people with all these horrible diseases. It can't be easy for you. And it's and no disease is exciting. You don't want to have any disease, but it's not all these people with these horrible, horrible diseases. It's not. It's not as scary as you think, and it's not as isolated as you think. It's everywhere. It's in the community. It's everywhere. So it's just educating ourselves and looking after our health, having checkups. So just having those checkups just to see that you're healthy, and just utilizing all the precautions that are available. I mean, there's a lot of things that I'm learning, and I think we can all just keep learning, keep exposing yourself to new knowledges so that we are informed, and we can, I guess we can contribute by destroying those stigmas and making people feel accepted and part of community, and by just our speech, how we speak of. Because when you're talking about, oh, you work with all these people with all these horrible diseases, the person you're sitting with could actually be a person who is living with HIV.
Yeah.
Because, so it's just, I think that education and that just being empowered within ourselves so that we're not caught up in concepts that ended in the 1900s, but we are still using them or few. We are not, yeah.
And it's that inherited judgment, and that we inherit this sort of judgment along you know, the through the generations about these diseases or these illnesses. And back then, maybe AIDS was as scary as leprosy. Who knew, you know? But
Yeah, yeah.
it's like our inherited preconceptions from whoever that we learned it from is not in touch with the current science. And so we continue to have this discolored lens on a lot of these illnesses that can easily be alleviated or changed by just a little bit of knowledge. So if someone like me would like to learn a little bit more about or about how to, I guess, demystify these stigmas,
Yeah, absolutely.
where would I go? How would I do that?
Like, I think on the anti-health website, there's a lot of information. There's also in the NT, there's NTAC, which is Northern Territory HIV and Hepatitis Council, and they focus on fighting those. They do a whole lot more, but they focus on fighting those stereotypes. So there are many organizations. Another one is ASHM, which is ASHM, and it's also like a national kind of body that shares all this knowledge and information. So even just a quick search on Google and just finding those reliable kind of sources, so like peak bodies and credible organizations that have real knowledge, which they have quite good information. Like the NTAC here in NT have really good posters which capture all sorts of families, and maybe someone is saying, I have HIV and I live with my boyfriend, but I don't have it because, or my husband is HIV positive, but I'm HIV negative, or my mom is HIV positive and I'm HIV negative. Just that dispel those myths, and also creating different viewpoints of not just these type of people have it, anybody, and it's all over through all populations. It's a disease like anything else.
Well, thank you very much, Mary. That was very educational, and I really enjoyed learning from you. So that
Thank
was
you for having me.
You're welcome. Yeah, I just wanted to recap again. So that was NTAC, ASHM, and the NT Health. These are the three places that we can start our education and search on sexual health and blood-borne virus, the stigmas and the myths around it, just to be able to educate ourselves and hopefully slowly educate the rest of the communities as well.
That's right.
Well, it's been really, really nice talking to you again. Thank you so much for your time. And I hope we get to speak soon, sooner than later.
Correct. Thank you, Amira. I hope so too.
All right. Thank you, everyone, for listening. And bye for now.